Heparin-induced thrombocytopenia. Definition: Heparin-induced thrombocytopenia (HIT) is characterized by a decrease in platelet count of more than 50% from the highest platelet count value after the start of heparin. An onset 5 to 10 days after the start of heparin, hypercoagulability, and the presence of heparin-dependent, platelet-activating Ig antibodies. The onset of HIT characteristically occurs between 5 and 10 days after heparin is started, both in patients who receive heparin for the first time and in patients with re-exposure. However, there are exceptions.
The purpose of this video is to explain what's happening in the body with intravenous heparin. Heparin is a powerful anticoagulant, which means that it stops the blood from clotting. It can aid in blood flow and can be referred to as a blood thinner. Currently, we have a patient who's looking a little blue. We want to give them intravenous heparin. Our first step is to set up their IV. Once we have the IV set up, we consult the order. Many times, the first part of the order is to give a bolus. The bolus is typically a large dose of heparin. Here, it is 80 units per kilogram. It is not per hour because it is given as an IV push. That means we'll use the syringe to administer the heparin through the IV tubing directly into the patient's veins. Their blood will distribute the heparin throughout their body for a nearly immediate effect. Let's give it a try. We'll calculate the amount of heparin by multiplying 80 units times the patient's weight. We'll pull the heparin into a syringe and administer it through their IV tubing. The heparin will flow into the patient. Now we see that the heparin is distributed throughout the patient. We see the patient in red. But the body is a living organism, and it is constantly working to eliminate foreign objects, in this case, heparin. So as time goes by, the heparin is eliminated from the body and the concentration of heparin decreases, meaning that the blood is more likely to coagulate. We would like to offset this, and so the second part of the intravenous heparin order is for a heparin drip. You'll notice that this is a significantly smaller amount, less than 1/4 the units. It is still per kilogram, which means we'll need to multiply by the patient's weight. It is also per hour, meaning that it is an IV rate that we will set on the infusion pump. So once we calculate the correct rate for the infusion pump in milliliters per hour, the infusion pump will add heparin to the patient's body, hopefully at the exact same rate that the body is eliminating heparin. And we once again restore the heparin level. But we may be wondering, did we get it right? Did we get the heparin level exactly where it should be? We need to test the patient's blood to see what the clotting time is. So we'll draw some blood and send it to the lab for an APTT time, a clotting value that is measured in seconds. based on the result from this test, we'll change or keep the heparin dose the same. We know what to do based on a heparin protocol. A protocol is a pre-printed set of guidelines. If we find that the blood is clotting quickly, we may need to administer another bolus, or we may need to increase the IV rate, or both. If the blood is clotting too slowly, we may need to decrease the IV rate. If the blood is clotting too slowly, our patient may be at risk for hemorrhage. If the APTT level is within the goal range, we'll know that we have gotten the administration of heparin exactly right for this patient, and so we'll continue the IV without adjustment. I hope that gives you a picture of what is happening with intravenous heparin. Our next step would be to look at an actual problem. On the bottom of your screen is a hot button that will allow you to go directly to a video explaining how to do an actual heparin protocol problem.
Pros. Heparin is generally used for anticoagulation for the following conditions: atrial fibrillation, cardiopulmonary bypass for heart surgery, hemofiltration. Cons: bleeding, headache, alopecia, osteoporosis, HIT.
In this video, let's have a look at the difference in mechanism of action of high molecular weight heparin, low molecular weight heparin, and fondaparinux. High molecular weight heparin, as the name suggests, it has a higher amount of polysaccharide units. And all the heparin molecules contain a pentasaccharide unit which binds the antithrombin. Upon binding of the antithrombin to this pentasaccharide unit, the antithrombin gets activated and further binds the activated factor 10A, and finally inactivates this activated factor 10A. As this high molecular weight heparin is a very long molecule, it also tethers the activated factor 2A along its length, and the activated antithrombin inhibits the factor 2A also. As heparin is a very long molecule, it binds both antithrombin and factor 2A, so that it inhibits the activity of both activated factor 10 and activated factor 2 in almost equal ratio, that is 1:1 ratio. Moving on to the low molecular weight heparin, it almost always binds the antithrombin and inhibits the factor 10A. The mean polysaccharide units in low molecular weight heparin is around 17, whereas for tethering of the factor 2A, more than 18 polysaccharide units are required, and therefore some of the molecules of low molecular weight heparin binds this factor 2A and deactivates the factor, whereas the other molecules are too short to bind the factor 2A and therefore inhibits only the factor 10. So that the ratio of factor 10A to factor 2A inhibition activity is around 2:1 or 3:1 depending upon the type of preparations. Fondaparinux is a synthetic pentasaccharide of the antithrombin binding site, so that it binds only the antithrombin and finally inhibits only factor 10A activity. As it is too short and binds only antithrombin and inhibits the factor 10A activity, The ratio of inhibition of factor 10A to factor 2A activity is 1:0.
Pathogenesis. HIT is induced by Ig antibodies recognizing neoepitope and possibly charged chemokine PF4 within PF4 polyanion complexes. Antidote to heparin overdose. Protein sulfate has been given to counteract the anticoagulant effect of heparin.
Blood cells are produced in the bone marrow. The three main components of blood are red blood cells, which carry oxygen, white blood cells, or leukocytes, which fight infection, and platelets, also called thrombocytes, which assist in the formation of blood clots. When a blood vessel is damaged, platelets adhere to the surface of the damaged vessel and release chemicals. These chemicals attract more platelets as well as red blood cells in order to form a clot or thrombus. As the clot grows, the blood vessel narrows, thereby decreasing blood loss. This process is called coagulation. Normal platelet counts are in the range of 150,000 to 350,000 platelets per microliter. Thrombocytopenia is a disorder in which there are not enough platelets. When the platelet count is decreased, the body is unable to form blood clots and therefore is unable to control bleeding. Bruising and bleeding can occur from relatively little trauma. When the platelet count gets below 10,000 platelets per microliter, bleeding can develop without trauma. Chemotherapy-induced thrombocytopenia is a disorder that develops as an adverse effect of chemotherapy. Cancer drugs not only kill cancer cells, they can also damage the platelet-forming cells in the bone marrow. The severity of this disorder depends on the type of chemotherapy and the duration of treatment. Fortunately, chemotherapy-induced thrombocytopenia can be managed with platelet transfusions, additional medications such as blood cell growth factors, or with blood stem cell transplants.
Diagnosis. Diagnosis of HIT is based on a decrease in the platelet count of more than 50% or thrombosis beginning 5 to 10 days after the start of heparin. Treatment. Key intervention in patients with highly suspected or confirmed acute HIT are the prompt cessation of heparin and the initiation of an alternative anticoagulant at a therapeutic dose.
ITP, more than just a story of platelet destruction. Sometimes it's a drop of blood, a nosebleed that won't stop, bruising, petechiae. In rare and more severe cases, life-threatening bleeding. These are all potential results of thrombocytopenia, a hematologic abnormality that arises from the autoimmune disorder immune thrombocytopenic purpura, or ITP. early research suggested that ITP was caused by a blood plasma factor. At the time, however, autoimmune disease was not well understood, and this theory was not widely accepted. It was thought that the spleen played a central role in ITP. It either made a factor that suppressed platelet production or destroyed platelets. A major advance in the understanding of the nature of ITP occurred when a young doctor named Dr. William Harrington volunteered to be infused with a pint of blood from an ITP patient. People without ITP, such as Dr. Harrington, are normally capable of producing approximately 100 billion new platelets every day through the blood cell differentiation pathway known as hematopoiesis. During hematopoiesis, large polyploid platelet precursor cells, known as megakaryocytes, typically each give rise to thousands of platelets. Newly formed platelets are then transported into the bloodstream. Megakaryocyte development and platelet production are dependent on their regulation by the cytokine thrombopoietin, or TPO. TPO binds to its receptor throughout hematopoietic development on stem cells, megakaryocytes, and platelets to mediate platelet production. While the liver produces TPO at a constant rate, the circulating level of TPO is regulated primarily by megakaryocytes and the number of available platelets in circulation. TPO bound to platelets is removed from circulation when platelets are normally destroyed. When there is a drop in the number of platelets, there is more unbound TPO in the blood, allowing it to bind to megakaryocytes and stimulate further platelet production. Within hours of being infused with the blood of an ITP patient, Dr. Harrington developed severe thrombocytopenia, with a platelet count reaching 0 within 24 hours. This finding, along with other experimentation at the time, led researchers to believe that ITP was caused by a plasma factor and was a disease of platelet destruction. It was later found that this blood factor is in fact found in the globulin fraction of the blood and is indeed an antibody. Through this early research, Dr. Harrington opened the door to understanding the true nature of thrombocytopenia in ITP. Furthermore, studies within the last 15 years revealed that the level of TPO does not appear to significantly increase in ITP patients as one might expect. Indeed, contemporary research suggests that ITP may also involve decreased or ineffective platelet production. How could platelet production be hindered in ITP patients? Although the bone marrow appears to have normal levels of megakaryocytes, they do not appear to be producing platelets at normal levels. Research suggests that megakaryocytes in ITP patients may not be developing properly. This theory has evolved from morphologic studies by Damashek from the mid-20th century, which suggested decreased platelet release from megakaryocytes in ITP patients. In addition, platelet survival studies in the 1980s implied decreased or only normal platelet production in most ITP patients, rather than increased production as might be expected by a marrow responding to a lower platelet count. Further investigation in children and adults by Nugent's and Macmillan's groups respectively in the early 21st century show that ITP plasmas can suppress megakaryocyte development in vitro leading to decreased platelet production in patients with ITP. Over a century of investigation by pioneers in ITP research demonstrates that ITP is a disorder involving increased platelet destruction and inadequate platelet production. This leads us to our current understanding that the bone marrow is an additional target of ITP.
Two drugs are approved for the treatment of HIT: the direct thrombin inhibitor argatroban and the antithrombin-dependent factor XA inhibitor danaparoid. Conclusion and recommendation. Platelet factor IV heparin antibody test should be ordered only if clinical features reasonably suggest HIT.
Hey guys, today we're going to talk about heparin-induced thrombocytopenia, but before we get into that, let's just cover a little bit about heparin itself. So as we know, heparin is used as an anticoagulant agent which inhibits thrombin, and it does this by activating antithrombin 3. So let's say we have fibrinogen, which gets converted to fibrin. And fibrin is one of the main important components of the coagulation cascade, right? So we don't want to make this fibrin. And in order for fibrinogen to get converted into fibrin, we need thrombin. So if we give the patient heparin, heparin will activate antithrombin 3, which will then inhibit thrombin. Therefore, we're gonna have inhibition of fibrin production. Heparin is also an immediate anticoagulant with a short half-life. Therefore, we can use it in conditions such as pulmonary embolism, stroke, DVT. We can also use it in pregnancy since it does not cross the placenta. And some of the important side effects of heparin are obviously bleeding, because we are inhibiting production of fibrin, osteoporosis, so if we have a patient who already suffers from osteoporosis, we obviously don't want to give her heparin. Instead, we can give her another drug in the heparin family, which is a low molecular weight heparin, and it's called enoxaparin, which does not cause osteoporosis, okay, which is a high yield point that we need to know. Okay, so enoxaparin. And lastly, another important side effect is heparin-induced thrombocytopenia, which we're going to talk about now. If someone receiving heparin develops a new or a worsening thrombosis, or if their platelet counts falls, we can assume heparin-induced thrombocytopenia. And here's why. Now, sometimes heparin acts as a hapten by binding to platelet factor IV. So here's our heparin. Okay, it binds to platelet factor IV and it forms a hapten. which will then stimulate the immune system, resulting in antibody production. Okay, so our immune system gets stimulated, and then we start making antibodies. These antibodies are usually of the IgG class, which will form a complex with heparin and PF4, which is our platelet factor 4, in the bloodstream. So let's just imagine that this is our IgG binding to heparin and platelet factor 4, forming a complex. Okay. Now this results in platelet activation, which initiates the formation of blood clots, leading to decreased platelet counts and eventually thrombocytopenia. So if we have a patient who suffers from HIT, he or she will be in a hypercoagulable state, and at the same time they will have thrombocytopenia. So how do we treat a patient who is suffering from HIT? Well, we can take them off of heparin and put them on either lepuridine or bivaluridine, which are alternatives to heparin, or we can give them argatroban. Either way, they all have the same mechanism of action, and that is to directly inhibit thrombin. So directly inhibit thrombin.
Thank you.